Thank you for joining the AACE Quality Payment Program webinar presented by Jill Rathbun and Michelle Cobb-King. Please note that all lines are muted for the presentation, and questions will be addressed at the end by using the chat option, which can be found in the lower left-hand corner of the screen. You're welcome to forward your questions at any time, but they will be addressed at the end of the presentation. At any of the time you need operator assistance, please dial 00. As a reminder, this webinar is being recorded. This webinar is to assist AACE members in understanding the 2018 QPP and will provide information on the final 2018 update and give guidance to successfully comply with program rules and to avoid a payment penalty. While the AACE Practice Management Department represents our best efforts to provide accurate information and useful advice, this information is taken from publicly available sources. AACE cannot guarantee reimbursement for services as an outcome of information and or the data used and disclaims any responsibilities for denial of reimbursement. This information is intended for informational purposes only. As a reminder, once again, for anybody who has joined late, the webinar is being recorded. And I'd like to now turn it over to Dr. Felice Caldarella, Chair of the AACE Payment Model Subcommittee, for opening remarks.
Thank you, Alyssa. Good evening. My name is Dr. Felice Caldarella. I'm the chair of the Payment Model Subcommittee here at AACE. Welcome to tonight's webinar, which will explore the aspects of CMS's QPP, or Quality Payment Reimbursement Program. Our primary presenters tonight will be Jill Rathbun. She's managing partner at Galileo Consulting Group, and Michelle Cobb-King, director of AACE's Practice Management Department. Ms. Rathbun has more than 19 years of experience in consulting with life sciences and healthcare organizations. Her areas of expertise include research and development funding, reimbursement strategy and pricing, market development, product launch positioning, and as well as government and regulatory affairs. She's been a consultant for AACE since 2009. Mrs. Cobb-King has more than 15 years of experience in the business of medicine. She's the head of our practice management department at AACE. Her background includes experience with Medicaid and Medicare, state-sponsored insurance programs, commercial insurance carriers, and public policy related to healthcare. And Mrs. Cobb-King has been with AACE since April of 2016. I now turn the floor over to Mrs. Rathbun and Mrs. Cobb-King.
Great. Thank you, Dr. Caldarella, and thank you, everyone, for joining us this evening. Hopefully everybody's recovered from the Super Bowl and is ready to learn much more about the MIPS program for 2018, as well as wrap up any activities that your practice needs to do to make sure that you avoid the penalty in 2017, because there's still a little bit of time to try to avoid that 4% penalty. So let's review what we're going to go over this evening as we spend some time together. So first, we're just going to go through a quick reminder about what is the Merit-Based Incentive Payment Program, otherwise known as MIPS. Then we're going to talk, as I mentioned, about how to finish up 2017, which is the year one of MIPS, to avoid the 4% penalty in 2019. Then CMS has made some changes for MIPS Year 2, which is 2018 for 2020 payment adjustments, and we want to make sure all AACE members get off on the right track for success in 2018. So we want to make sure you're well aware of these additional requirements and changes that CMS has made. And then we hope to answer your questions this evening. As Alicia mentioned, we do have a Q&A box, and we hope that you will write your questions into that, and feel free to write them during the presentation, and we'll try to pick them up as we go along so that they'll be timely with what we're going over on the slides as well. So, and then Michelle's going to talk some at the end about the AACE tools for members, and there are many of them, and they're very exciting, and we're going to share that with you. So let's talk a little bit about just general MIPS, and I want to let you know that these slides that we're using this evening are directly from the Centers for Medicare and Medicaid Services, directly from the Quality Payment Program, and their slide decks that they have used in their educational webinars as well. So this is coming right from the regulator's mouth, so to speak, and we're looking forward to sharing it with you this evening. So just a quick reminder that, as Dr. Caldarella said, we now have this new program called the Quality Payment Program, sometimes referred to as QPP. This came to be because Congress passed a law called the Medicare Access and CHIP Reauthorization Act of 2015, sometimes referred to as MACRA. And that law created two programs, and physicians need to be in one or the other to avoid payment penalties and to earn bonus money. So the first program, and the one that most physicians are in today, is called MIPS, the Merit-Based Incentive Payment System, and it's pretty much a quality reporting type program. Then the other program is Advanced Alternative Payment Models. They too have quality measures involved, but they require physicians to take risk in regards to managing patients' costs more aggressively, and they are predominantly available to physicians that are in accountable care organizations, and there's a couple that are specialty specific. We don't yet have one in diabetes, but AACE is actively working on that and hopes to have something available for its members soon. So the MIPS program is basically a combined program of the old quality payment programs that all are now ceased to exist. You are getting payment adjustments in 2018 based off these old legacy programs based on what you did in 2016. But after this year, they're totally no longer available. So one was the old PQRS program, Physician Quality Reporting System. Then we had the Value-Based Payment Modifier. That's the one that brought cost into the equation. And then we have the Medicare EHR Incentive Program, otherwise known as sometimes as Meaningful Use, or the Electronic Health Record Requirements. So those three programs have basically now been merged into this one program called MIPS. And that's what we're going to talk about mostly this evening, is this program and how to be successful. So who's included in this program? Well, there's multiple different types of professionals, and it's the same group for both 2017 and 2018. CMS did not change who was covered under this program in 2018. So it's physicians, it's physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. So if you practice in your practice with physician assistants and nurse practitioners, they would be counted as eligible providers under MIPS, and they would need to be participating as well in your group. So that is something to be aware of. It's not just physicians. Also, who is included in MIPS in regards to exemptions. So the first exemption, a very major exemption that was in place in 2017 but has been increased for 2018, is the low-cost threshold exemption. So in 2017, if you were a provider that billed Medicare less than $30,000 in allowed charges and you treated less than 100 Medicare patients, you were exempt from the MIPS programs. You were exempt from the quality payment programs. You were exempt in general. And so that was good, and now CMS is expanding that program. So now in 2018, if you billed Medicare less than $90,000 in allowed charges and saw less than 200 patients that are Medicare, you would be exempt. And you can check your participation status. I'm going to show you some screenshots here in a minute of the QPP website, and I'll show you where you can do that. And that's something that's important to do at the beginning of every reporting year. So now at the beginning of 2018, it's also a good thing to do toward the end of the reporting year, because CMS checks data over the course of the year, particularly to see which physicians are covered by alternative payment models. So again, you'll want to be checking this at least twice during the year. So who else is exempt? Well, there's two other categories that are exempt, and one is someone who's newly enrolled in Medicare. So if you're newly enrolled in Medicare, you newly enrolled in 2017, maybe you just started practice, you would be exempt for that year. Or if you're in an advanced alternative payment model, you're exempt if you're meeting the threshold for the number of Medicare payments or patients that are covered by that model. It's a good reason why you need to check your participation status so that if you are participating in an accountable care organization, that you understand whether you've met the thresholds such that you're qualifying under that program versus having to do MIPS. So those are sort of the basic tenets of the programs. And now we're going to talk a little bit about 2017 and how you can still finish up, so to speak, make some attestations to avoid the penalty, and you have a little bit of time if you haven't started doing anything. So 2017, CMS offered a program called Go at Your Own Pace. It allowed people to transition in 2017 by just trying to do something, a quality measure or an improvement activity or meaningful use. They also had shorter reporting periods. All the reporting periods for 2017 were 90 days. So the last reporting period started on October 2nd. Also, cost was not included for 2017, so no one's cost will be attributed to their score. So as I mentioned, in 2017, we have this ability that all you need is 3 points out of 100 to not have your payment adjusted at all. So as long as you don't do 0, i.e. do nothing, you will not have a negative adjustment of 4%. So if you at least do some clinical improvement activity or some quality measure reporting, you got 3 points in 2017 and you avoided the penalty. So you may be saying to me right now, well, but it's February 5th, 2018. 2017 is over. Well, that's true. But CMS is allowing everyone to submit their data by March 31st, 2018. So if you haven't done anything, this would allow you to go back into your practice, particularly around a clinical improvement activity, and document that you did that activity back starting October 2nd through December 31st. And then I'm going to show you in a minute, you can go on the CMS website and attest to that activity that you did it. You do have to hold on to your documentation for 7 years that you did the activity for 90 days during 2017, but it would help you avoid a 4% payment penalty in 2019. So really important here that if you've done nothing and you're unprepared for 2017, that you go back and find that data for a clinical improvement activity. That's probably the easiest thing that you can do to avoid the penalty. And what you do is you go on to the Quality Payment Program website, which is www.qpp.cms.gov, and we'll show you that link again in a minute. And this is the front page of the website. Remember I mentioned that you're going to want to check your participation status? Well, right on the front page of the website, you do that. You just type right in your NPI number, click it, and it'll give you a whole report in regards to whether you are covered in an alternative payment model or whether you have to report under MIPS. So this is really important that you're checking your participation status early, both for 2017 and 2018, so that you know whether you need to scramble here in the next 2 months and get in some data before March 31st. Also, while I have this screenshot up, there's also nice clicks here. So there's a click here at the top for the MIPS program, tell you all about the various quality measures, the various improvement activities. Also click for APMs. It'll show you lists of the APMs that are available, whether they're MIPS APM or advanced APMs, general information about the quality program, and then we're going to talk here about this sign-in portal, which is how you're going to attest to your electronic health record participation or your clinical improvement activity participation, or if you're doing your quality measures through a large group or an accountable care organization, there's a portal for that. So first, when you go into the sign-in, you sign in using your EIDM credentials. These are the same credentials that you used to use to check on your PQRS participation. These are also the credentials you use to get into the CMS site when you're re-signing up your participation papers with the Medicare program. So your practice manager should have your EIDM credentials, or your group practice plan will have its EDIM credentials, and you would sign in with those credentials, and you would then put in your password that you would have created at that time and sign in. So this is something that you can do, and will be helpful to have these ready when you want to sign in. Then it's going to send you a code to your phone, and you're going to type that in so that they know it's you, which is important. You don't want somebody trying to put in data that's not you or your practice manager. So here, once you log in, is the screen that it's going to show you. And this is where you want to click Start Reporting for improvement activities or advancing care information or quality measures. Now, again, as I mentioned, if you haven't started anything for 2017, I think that doing the improvement activities is the easiest way to go between now and March 31st. Easiest way to go back and document the activities. There are 92 activities to choose from. Many of them are around patient engagement, patient satisfaction, quality systems in your practice, i.e. things like making sure that you have a process in place to give the referring physician back a report about their patient, which I'm sure most of you, that's a routine activity because you're working with primary care on diabetes patients, going back and forth. I'm sure that many of you have other improvement activities that you're doing that will match up to the list of 92 in your practice around patient satisfaction, around making sure that the patient is aware of having a plan for their care, which I'm sure many of you are already doing as well. So that's why I think if you've done nothing, your practice has done nothing to avoid the 4% penalty, going through those 92 improvement activities, picking one, going back into your practice to document that you did it over 90 days, and then going here to the website to attest to the reporting by clicking on this Start Reporting after you've logged in is probably the easiest way to be in a position to avoid the penalty. Now again, if you're using an electronic health record, just to be safe, I would also do Start Reporting on advancing care information. If your electronic health record does e-prescribing, if it has a patient portal, all these things would be parts of that program, and you could start reporting and put that in, because if you have an electronic health record, of course, you probably had it for over 90 days. So that would be the other thing to do to cover. Also, just to be safe, if there's more than one improvement activity of the list of 92, you can document you've been doing for 90 days starting on October 2nd. I would put in more than one, right? Always good to have a little bit of extra cushion in case. So again, we need to work in the next 60 days to make sure that every one of you goes into the website, the QPP website, logs in with your EDIM number, documents, attest to the fact that you've done an improvement activity, and if you have an electronic health record, how it works for the advancing care information requirements, and that you do everything you can to at least get those 3 points, to at least have tried. Also, again, as I mentioned, I'm just going to go back here quickly. If you've never checked your participation status, now is the time to do it, because otherwise, if you never check it, you'll never know, and you might get the 4% penalty, and we would hate for that to happen. So again, it's a good time to check your participation status for both 17 and 18, so you can make a plan in the next 60 days, but also because I'm about to tell you that the requirements are increasing for 2018, you can also make a plan for 2018. So 2018, I'm just going to take a breath here and see if anybody has any questions regarding 2017 and what you need to do in the next 60 days, if you haven't already, to avoid the 4% penalty. So any questions that people would like to type in about 2017? Or Michelle, anything you'd like to add? Or Dr. Calderella?
No, Jill, I think you covered it.
Okay. Well, we'll just take a minute here. Any 2018 questions? Or, excuse me, 2017 questions? Okay. Good. Well, we'll keep rolling then. So now we're on to 2018. So 2018 is year 2, and CMS very much wants physicians to continue to transition into the program. That's why they're increasing the requirements. So they're changing the performance periods for 2018. This is really important because remember I mentioned that all the performance periods for 2017 were 90 days, which meant if you started January 1st, you only had to do it for 90 days and you were done. Or if you didn't get ready in time, you could start on October 2nd, do some claims-based quality measures for the 90 days till December 31st, and you'd be done. Well, that's not going to be the case for 2018. So for 2018, CMS is increasing the performance period for quality measure reporting to 12 months. That means that if you didn't report any quality measures in January, you're going to need to go backward and re-report quality measures for January. Now, Michelle interviewed Dr. Victor Roberts. Maybe some of you know Dr. Roberts, practices in Florida, about his work with the diabetes registry that AACE does with the American College of Cardiology. I would say that if any of you are interested in that, it would be a fabulous time to get signed up because with 12 months of quality measure reporting requirement, the best way to do that is a registry. Particularly the one that AACE has with cardiology has many, many, many different electronic health records that it will work with such that you wouldn't have to re-enter any data. So really encourage you to read this article we have coming out and to contact Michelle post-haste about getting signed up for the diabetes registry. Also, cost is going to be a 12-month reporting period, but CMS will be calculating that data for you off of your claims data, so you don't have to do anything. Improvement activities will again be 90 days, and advancing care information, again, meaningful use of electronic health records, will be 90 days. So CMS has also changed the weighting structure on the performance categories for 2018. They did decide to go ahead and put cost back into the structure. So your quality score will be worth 50 points. Your cost will be worth 10, improvement activities 15, and advancing care information 25. So that means the points from each of these performance categories are going to be added together to give you your MIPS final score. And we'll show you in a minute how many points you need in 2018 to avoid the penalty. And also, we will show you here in a minute, CMS has a couple areas where you can win some bonus points to help you get to your 100. So again, CMS is going to allow data submission through March 31st of 2019. That doesn't mean you want to start again and not do anything until next January or February. That would be trickier now because of the quality measure reporting period going up. The performance period does close on December 31st. It did start on January 1st. And everything you do this year will affect your payments in 2020. So once we hit March 31st, 2019, there will be nothing that you can do to impact what will happen to your payments in 2020. So now is the time to make a plan and to get prepared and to start your activities in MIPS year 2. So just as we had in MIPS year 1 in 2017, you can report as an individual, which is one MPI number assigned to one tax ID number. You can report as a group. That means you have to have at least 2 or more clinicians. Remember, that means nurse practitioners, physician assistants, clinical nurse specialists, etc. And you can also do a virtual group. Now, CMS had a very short deadline for virtual groups for 2018. We are going to spend some time talking about this evening so that you can get organized to potentially be a virtual group for 2019. Because the deadline was December 31st, 2017 for 2018, which CMS actually didn't publicize that very much. But this will allow you to get organized for 2019 as a virtual group if you're a small practice and think that that could be a way for you and others, ACE members in your community, to come together and report. So let's talk a little bit about these virtual groups, because I know many of our ACE members are in small practices, and this might be an option to share resources and share activity and load to be able to do the MIPS program. So
hey, Jill, this is Michelle.
Yes.
We've received a request via the chat room that you go back and discuss cost, because one of our members will be billing using paper bills.
Okay. Well, we're coming up to cost, so we will do that. Okay, good. Oh, yes. Okay. Yep. And we're going to hit a slide here in a minute about reporting methods too. So let me think a minute here. Let's jump over virtual groups for a minute. Okay. So here, let's talk about the submission methods, and then we'll talk about the various performance categories in a little more depth. And I think that'll help us with our two questions. So first, there are multiple ways to submit data, as there were in 2017 in 2018. So as I mentioned, you can submit your quality data via a registry. There are these registries called QCDRs, which is Qualified Clinical Data Registries. The ACE Diabetes Registry with Cardiology is one of those. There's also qualified registries, which are basically most of the QCDRs are also qualified registries. Many of the electronic health records now, companies are starting to offer the ability to do quality measure reporting under the MIPS program. You may have to pay an extra fee, but they are starting to offer that. Also, you can do claims-based reporting. So if you're doing CMS 1500 claim forms, there are some quality measures, not many, but some quality measures that can be submitted on your actual claim. Whether that's a paper claim or an electronic claim, it's your billing claim. So that's quality data can go in that way. You just have to be very cognizant of which measure you're reporting and whether they're eligible to be submitted via claims. Cost, CMS calculates that cost score off your own claims that you're already submitting to bill Medicare for that patient's activity. So you don't have to do anything else but continue to bill Medicare for the care you provide to your patients. Improvement activities, again, you can do attestation. That's the process I just showed you off the QPP website. That is what is known as attestation. There are about 12 improvement activities that are tied directly to someone participating in a qualified clinical data registry or a qualified registry, and those registries would submit that information for you. And then advancing care information, you can do attestation, like we just showed you for 2018 on the QPP website. Or if your qualified clinical data registry is pulling, or what we call abstracting data from your electronic health record, they would be able to report for you, or your electronic health record company can report for you. So when I mentioned that participating in a registry can be very advantageous to your practice, one of the reasons why I mentioned that is because, as you can see, of the quality, the improvement activities, and the advancing care information, registry participation for a qualified registry may help you do all three of those activities by doing one thing, right? And then CMS does the rest with the cost piece. So that could be very beneficial to your practice and to your workload. This year, you have to use one method per performance category. Next year, CMS is going to allow you to do split method, where you could do some quality measures by a claim, some by EHR, some by registry. Same with the other activities. I think, to be honest, that's going to be more confusing for them and for us, but they seem to want to do that. But for 2018, one method per category is how the submission will go. Okay, so Oh, Dr. Calderella has a good question. Where can you find lists of quality measures and performance improvement projects? Okay, I'm going to go backward here really quick. Don't get slide whiplash. So on the QPP website, Quality Payment Program website, at this little click on the top dashboard that says MIPS, if you click on that, it will say quality measures, improvement activities, clinical information, i.e. EHR. If you click on the quality piece, it'll give you all the quality measures, and they're searchable. If you click on the improvement activities, it'll give you all the improvement activities, and they're searchable. So right here is your dashboard. But Michelle, on the AACE macro website, you also have some lists of measures and improvement activities that folks can get to right off the AACE website.
Correct, and I will be going to the website when I begin my part of the presentation.
Okay. So be alert, everybody. We're going to have more information on that here in a minute. Okay. So now I'm going to quickly whip back. Okay. So we have our quality component. As I mentioned, it's now a 12-month reporting period. This year in 2017, it was worth 60% of your score. Next year, it's going to be worth 50% of your score. Now, here's what I really want to stress for everyone. Right now, for 2017, if you reported on 50% of the people of the cases that qualified under that measure, it was termed being data complete, right? That you had met the data completeness threshold, and thus you would get 3 points for that measure, and you might get more depending on how your actual score was on it. What's changing in 2018, and this is really important because, again, as I mentioned, you have to report a quality measure for 12 months. Also, now you have to report it on 60% of the patients that qualify under that measure. And if you do not meet that, you only get 1 point for that measure, right? You can't get more points. So that's problematic. Now, if you're a small practice, and we're going to give you that definition here in a minute, you can still receive the 3 points even if you miss the data completeness 60%. So it's really important that you pick your measures wisely in regards to ones where the denominator or the patients that are covered by the measure is one that's easy for your practice to capture that data, whether that's in a registry or whether that's on a claim or whether that's in your EHR. That those patients are easy to find in your medical records, that the coding is easy, and you can find at least 60% of them and report on them that you did the quality measure or the reason why you didn't do the quality measure. So that's really important. CMS is again saying that the top number of measures that you need to get the most possible points is 6. You can do less. We'll show you that in a minute in regards to just trying to not get penalized. But 6 measures is the top, and as we mentioned, there's now over 270 measures. There's a few less than 2017 because CMS is taking some of them out of the program. But so quality is still a big part of this program, and it's a part that CMS continues to change. There's also a whole scoring system now related to whether the measure has a benchmark or not. We have a number of measures that don't have benchmarks. If a measure doesn't have a benchmark, it's only worth 3 points, and that's the best you can get. So again, pick your measures wisely. There's 270 of them to pick from, and it's something that you do want to spend some time on, making sure you pick measures that have benchmarks and measures that you can easily find those patients in your data and get them reported on. So we had a question earlier about cost. So let's talk about cost. So CMS is going to calculate your cost score, not unlike how they calculated cost scores in the value-based payment modifier. So your score will be calculated on the data that you send to CMS via claims, whether that's paper claims, electronic claims, however you bill CMS for the care you provide patients, that is their claims data on you, and that's what they will use to calculate your cost score. Now, this year they're going to use 2 different metrics for calculating cost. One is Medicare spending per beneficiary, and one is total per capita cost. So both of those cost scores are going to include both Medicare Part B, which is physician cost, and Medicare Part A, which is hospital cost. Eventually, CMS is going to make cost measures that are more episode-specific or condition-specific, like chronic care for a patient with diabetes. But to date, they're just using these very general Medicare spending and total per capita cost per year per patient. So that's what they'll be scoring your cost score on for 2018. And again, it's on whatever claims data you have submitted and whatever claims data that CMS has on that patient from other providers and from hospitals. So it's all data they have in their system. You don't have to put in anything extra. So that's how they'll do the cost score. Then, as we said, you're not required to submit any additional information. Your performance, your cost performance is compared against performance of other MIPS eligible clinicians and groups during the performance period. So again, they're going to put these 2 scores, calculate them on you as a provider or your group as a whole. And then they're going to line them all up and see how people do relative to your peers, other clinicians, and then they'll set benchmarks and they will assign points, right, based on how low or how high your costs are. So then we have the improvement activities. As I mentioned, for 2018 now there'll be 112 activities. CMS added several new activities for 2018. All you're going to do is attest a simple yes when you go and do the attestation on the QPP website. Again, to receive your total points for improvement activities, you need to have done 40 points worth of activities. Each medium activity is worth 10 points, and each high-rated activity is worth 20 points. If you're in small practices, you do not have to do more than 2 activities to get your 40 points. So if you did 4 medium activities as a regular practice, if you're a small practice, you would only have to do 2 medium activities and you would still get your 40 points. So again, clinical improvement activities are probably one of the easiest things to do in the MIPS program because they're things that you're already doing. And it's just collecting the documentation that you're doing them and then going to the portal and attesting yes that you did them. So again, it's probably the easiest thing to do. Also, as I said, CMS added some new activities, and the scoring, again, is related to medium, 10 points, high is 20 points. You need 40 points total. And for group reporting, it's only 1 MIPS eligible clinician at 10 must perform the improvement activity for the whole 10 to receive credit. So 10 is your tax identification number for your group. So if one clinician in your group does the activity and you, let's say, have a group of 100 physicians, all 100 physicians get credit for the work of that one person. So as I said, the improvement activities are really about the simplest thing to do in the program. So advancing care information, that is our meaningful use of electronic health records. This is where 25% of your score, 25 points. It's about supposedly promoting patient engagement and the use of electronic health records. You do not have to have a certain certification. You can use 2014 or 2015. This is something that your EHR vendor would know what year they're certified for. If they do have you certified up to 2015, you would get a 10% bonus on whatever your score is in advancing care information. They haven't changed the base requirements, i.e. the 5 base measures. Again, it's a 90-day reporting period. Again, you can get a 5% bonus if you're reporting to additional registries using your electronic health record. And again, you can get some bonuses for using your advancing care information in improvement activity work. So again, you can get a number of different ways to get bonuses on the Advancing Care Information Program, i.e. because CMS really wants all physicians to start using electronic health records. And they really want those electronic health records to have particular abilities like e-prescribing, patient portals, patient engagement, ability to work with registries, etc. So they're giving some bonus points to try to foster that along, both in regards to the EHR vendors and in regards to physicians adding those features to their systems. So here is some different pieces. I want to remind people there's a hardship exemption program in the Advancing Care Information. You have to be in a small practice, 15 and under. If you're in that small practice, CMS will not apply the 5-year limit. You do have to get that hardship exemption in by December 31st of the performance year. So for 2017, if you didn't get your hardship exemption in by December 31st, you're not going to be able to do it. But you want to mark this on your calendar because you want to get, if you need to get a hardship exemption in for 2018 and you're a small practice, you want to get that in before December 31st, right? Really important. If you get a hardship exemption, they'll do some re-weighting, and you'll end up with your quality piece being worth more than 50% and your advancing care information score not being necessary. So this is important if you're struggling with your electronic health record and getting it up and running in your practice, and you're a small practice, is to make sure you get the paperwork in on time for a hardship exemption. So as I mentioned, CMS has some new bonus programs, for better word, in the MIPS scoring. One is for improvement, and you can get up to 10 bonus points in the quality category if you are showing a rate of improvement over time at the quality level category. Similarly, you can get up to 1 bonus point if you're showing improvement in cost. So this is part of the macro law that the scoring system would give credit for improvement. And at the moment, this is the way CMS has decided to give the points out for the bonus for improvement. So again, quality is a bigger piece of the program, so more potential bonus points than cost. But as these two programs pieces start to align, i.e. with quality and cost being equal over the future years, this improvement piece will probably align more that way too. But there is the ability to get bonus points for improvement. Now, as I mentioned, so I'm going to take just a short breather here, make sure that I've gotten to all of our questions so we're not missing any questions. We want to make sure we get to all of our questions while we're going here. Okay, yes, please keep typing those questions in. That's good. We want to make sure we're getting to all of your thoughts. So as I mentioned, this year for 2017, if you made a 3-point threshold, if you at least got 3 points, did one activity, one clinical improvement activity or one quality measure, you would get 3 points. You would not get the 4% payment penalty. And if you did the whole program and got up to 70 points or more, that gets you into what we call an exceptional performer program, where there's extra money, extra bonus money to be given out at about to those people who get in that group. For 2018, CMS is increasing the threshold of points that you have to get to avoid the penalty, and by law the penalty goes up to 5%. So you have to get at least 15 points to avoid the penalty. So how could you get 15 points? So CMS gives us a couple different examples. One is report all required improvement activities. So get all those 40 points for improvement activities would give you 15 points overall. So 4 medium improvement activities or 2 high improvement activities. That would give you 15 points. Or you could do the base 5 measures for advancing care information and do 1 quality measure that meets data completeness, and that would give you 15 points. Or you could get the base measures for advancing care information. There's 5 of them. Do 1 medium weighted improvement activity, and that would get you 15 points. Or you could submit 6 quality measures and at least get the data completeness part of them, even if they didn't have benchmarks, even if you didn't score very well on them, you would get 15 points. Now, if I was practicing today as a physician, I would be doing the improvement activities to get my 15 points. They're the easiest. You can do them only for 90 days. You can attest within your practice through documentation. Then you go on the CMS website, the QPP website, and you're done. That would be the easiest. The next easiest would probably be, if you have an electronic health record system, would be to do the 5 base measures for advancing care. Make sure your health record has those features. Document it. Again, go to the QPP portal and attest to that you had all 5 of them, and then submit 1 quality measure through your electronic health record for data completeness. Now that's if you're just trying to avoid the penalty. But what about, trying to get some big bonus money? I would do the quality measures. I would do it through a registry because I would also get all of the points for the improvement activities, plus I get my quality measure points. I might not get to 70, but I'd be in the upper tier and I'd probably get some bonus money. So you really have to think about what's your goal. Is your goal to avoid the penalty? Is your goal to try to get some bonus money? Or is your goal to try to get the bonus money plus the exceptional performance money? So that's something to think about. As I said, each category, 50%, also equivalent to 50 points, 10%, 10 points, 15%, 15 points, 25%, 25 points. Right? That's why you can just do the 4 improvement activities or the 2 improvement activities, get your 15 points, and you avoid the penalty, right? Because it would be 15 out of 100. It's additive. You get your points plus any sort of these special adjustments that I just mentioned. You could get those as well. There's also another special adjustment that I think many ACE members should be able to get, and that's for treating complex patients based on their medical complexity. You can get up to 5 bonus points for treating complex patients. It seems like a no-brainer for an endocrinologist, right? And this is based on, did you get all of the ICD-10 diagnosis codes on that patient's claim for everything that's wrong with them? Their hypertension, their neuropathy, their eye conditions, and obesity, BMI, all the things that are happening to them that make them a complex diabetic. If you get all those ICD-10s on there, you're going to get the 5 bonus points probably for treating patients. But you have to submit data in at least 1 performance category to get this bonus, right? So again, clinical improvement activities, get your 5 bonus points, you're looking good. Okay, now there's also a bonus if you're a small practice.
Michelle, if I could interject here.
Sure.
This slide is something that we talk about when we do our billing and coding courses, and that is coding to the highest level of specificity. It is now more imperative than ever that you code and code properly and in detail, because it will make a difference in your reimbursement through bonuses. Thanks, Jill.
That is correct. That's a good tip, Michelle. That is exactly right. It is now more important than ever. So then there's also a small practice bonus. This is if you're in a practice of 15 or fewer clinicians. Remember, clinicians includes nurse practitioners, PAs, clinical nurse specialists, registered nurse anesthetists. you'll get 5 bonus points if you're in a small practice, again, as long as you submit data on at least one performance category during 2018. So on quality, on improvement activities, on advancing care information. So if you do some activity on any of those and you're in a small practice, you'll get 5 bonus points just for being a small practice. Right? So again, you're an endocrinologist, you're in a small practice, you did good coding specificity, as Michelle said, you get 5 bonus points for complexity, you get 5 bonus points for being a small practice, you did your improvement activities, you get 15 points there, you're at 25 points. You'll definitely avoid the penalty, and we'll have to see how everybody else does to see if you get any bonus money. But you would be in fine shape then in 2018. So again, this just gives you a sense of the fact that the one thing that's really changed is what it takes to avoid the penalty. So in 2017, it took 3 points. In 2018, it's going to take 15 points. To get any sort of positive adjustment, you've got to get up over the 15. If you get over 70, you get into the exceptional bonus pool plus your positive adjustment. If you get, unfortunately, 0 points, or, well, basically almost 0 points, you're going to get the whole negative adjustment of 5%. If you do something but you don't get to 15 points, you're going to get some negative adjustment, but as long as you do one quality measure, even if you meet the completeness, you would get some negative adjustment, but not all 5 points of it, not all 5%. So this gives you a sense of the fact that we're starting to do gradation on the negative side, which the law requires. So CMS is starting to set the bar of when you get the full 5% penalty and when you might get less than the 5% penalty. So that's something to be aware of. But again, let's all try really hard now in 2018 to get the whole 15 points to avoid the 5% penalty. So CMS has quite a bit now of technical assistance that CMS provides. This is grants that CMS has given out to different entities, different technical assistance groups. The QIOs have been around for a very long time. There's some other, the QPP website, as we mentioned, at CMS headquarters. They also have these contracts for small and solo practices that are free to you. This is free. All to you. Again, they have one just for primary care. So these are all free technical assistance that CMS provides to you to come to your practice and help you to do your MIPS quality reporting. CMS also moved their resources. I'm not sure why. I wouldn't have done it, but they did. They moved their resources, so all their slide decks, all their videos, all their handouts, etc., they moved them back over to the CMS website off of the QPP website. So here's the new direct links to those things. If you go on the QPP website, they will just redirect you. But they did move it all. They do have some very nice YouTube videos. We have some of those on the AACE website too. So that's pretty helpful, and they have all the different handouts. They also have all the measure specifications, all the lists of measures, all the lists of qualified registries, all of those types of resources as well in these big resource libraries. So now Michelle is going to share with you about the AACE resources and for AACE members, and how you can ask your macro questions all year long to AACE. And then we'll go back and talk a little bit about data completeness on the quality measures again.
Jill, you have one question pending. You have somebody that says you've referred many times to completeness.
Right, that's the one I'm going to come back to in a minute. Yep.
Okay.
So I've just switched over, and everyone should be viewing my desktop, which is the AACE web page. In order to get to MACRA, you have two paths you can take. You can go to the Advocacy tab and then go to Socioeconomics. And as you scroll down, you will notice that there is a Are You Ready for MACRA? And if you click on this, it will bring you to the MACRA web page for AACE. Well, we have began updating the web page for 2018. As you can see, we've added a brand new button, if you will, for the QPP program for year 2. It gives you an overview of the highlights of what we've gone over tonight. But we were also reluctant to take down what we already had for 2017 because we are well aware that 2017 is really not over. The reporting period does not end until March 17th. So we've left up the details for 2017, and if you scroll down the page, you'll be able to see where we've still have the details and descriptions of how the payment program is divided into two. Also, things about MACRA implementation, the AACE activities that we've done so far, but we also have resources and links to other documents to enrich your learning experience on MACRA and QPP. We also have just some tools, if you will, to see if you're prepared for MACRA for 2017. We also have a listing of potential quality measures that you could use as an endocrinologist. When we checked around and Dr. Caldarella had some discussions with his counterparts, they felt like this was the best list for endocrinologists to select from, which were actually endocrine specific. The other site that I would like to show you this evening is the QPP site for CMS. So as Jill stated earlier, as you see, this is the opening page for the CMS QPP program. The first thing you see is that you can check your participation status, as she said. But some of the things that she talked about were the actual information that you can receive about the different quality measures. And if you click on the MIPS tab at the top, you'll be able to see that you can explore the different and various measures that CMS allows for reporting for 2017 and 2018, I believe. Is that correct, Jill?
Right. That's right.
So this website, as Jill stated as well, is more robust than anything I've ever seen CMS do in the past. They've gone all out, if you will, trying to come up with a user-friendly website that is very knowledgeable and filled with pertinent information. Because sometimes they have not so pertinent information on their websites, unfortunately. Also, in addition to that, you can also see that AACE has its own MACRA mailbox. If you have any questions or need any additional information or would like to speak to myself or Jill regarding any of anything that we said tonight or any questions you may have, you can submit those to the MACRA web mailbox. That address is MACRA, M-A-C-R-A, info, I-N-F-O, at AACE.com. These resources are specific to endocrinology, and they are specifically designed for our membership so that we can help you get through this process with the least amount of worry, concern, angst as possible. We are here for you. As I stated, we also do coding courses, and within our coding courses, we talk about MACRA. We talk about coding to the highest level of specificity, and it is so important now, just reiterating than ever, that you code to the highest level of specificity. It will affect you in all areas of your practice. Jill, I'm done. Back to you.
So, Michelle, on the macro webpage, is there information on the diabetes registry with cardiology?
I do not believe it is,
okay.
But all they need to do is contact me, as you stated previously,
yep.
And I can get them all the information they need.
Okay.
I don't think
Dr. Roberts' article, when is that coming out?
It's coming out in the next edition of First Messenger. I believe that will be the March-April edition.
Yeah, so everybody be on the lookout for your March-April edition of First Messenger and this interview article.
It's probably going to go out in online news as well.
Online news, too.
In the next 2 weeks.
Okay. Yeah, that's one thing, everybody, to remember, that we do several articles, Michelle, myself, Sarah Milo, Dr. Caldarella, we do several articles over the year in all of the AACE publications, online news, First Messenger, adding, as Michelle said, new information to the AACE macro webpage. You really want to make sure that you're reading those materials. Many times we have, like the nice sheet that Michelle showed you, we had that as an early article in First Messenger, I want to say, earlier this year. We also have this new article coming, as well as new stuff on the website all the time. So let's go back here a minute and talk about quality measure completeness, because this is really becoming much more important. Okay, so when you look at a quality measure, so Michelle just showed you on the AACE macro website that nice list of quality measures that might be good for endocrinologists. So when you look at that list of quality measures and you then decide which measures you think might be good, you have to go into the CMS website, on the QPP website, like Michelle showed you, where you click on quality, look up the measure, and download what's called the measure specifications. Now, why is that important? Well, the measure specifications tell you which patients belong under that measure. And the specifications are based on either CPT codes, i.e. the measure is based on procedures that you did for patients, and that's how patients are included in the measure, or it's based on ICD-10 diagnosis codes, like all patients with diabetes, and it would have all the diagnosis codes for diabetes. And then you would know that it's those patients with those diagnosis codes that you have to capture at least 60% of them in your practice that you saw, and then whether or not you did that activity that's in what's called the numerator of the measure. It's also done with codes, right? Either procedure codes usually, or G codes if it's an activity that doesn't have a code. So it's really important that you select your measures, then go look at the measure specifications, see how easy it would be because you use a super bill or something like that, where everybody, as Michelle said, is documenting the coding to the highest level of specificity, so you can easily find those patients in your patient records, and then either put their data in the registry or have them identified in your electronic health record so that your electronic health record provider can easily submit the data. Or if it's a claims-based measure, you have to put certain codes for the numerator to show that you did the measure. So it's 60% of the patients that qualify under the measure. And so on the AACE macro site, on the QPP site, we have specifications. So it's basically capturing at least 60%, i.e. reporting on at least 60% of the patients for whom the measure applies. And it applies because they're in the denominator, or they're the group of patients for which that activity is supposed to be done for. And that's how the completeness threshold is calculated. And CMS looks at your data, looks to see how many of those patients you had and whether you got 60% of them reported in to the quality portal as having that activity done for them. That was the activity in the quality measure. So it's a little confusing, and something that we'll continue to write on, but and we'll show you different specifications in some articles and things. But this is really important. Otherwise, you won't have enough patients that you reported on that you did the quality measure, and you won't meet the completeness threshold, and thus you'll only get 1 point unless you're a small practice. So that would mean that even if you did 6 measures, if you didn't meet the completeness threshold, you would only get 6 points. That's not even enough to avoid the penalty. So we have to make sure that we are capturing at least 60% of the patients for whom the quality measure applies.
Also, I wanted to bring up something that is near and dear to my heart living in Florida, is that part of the year 2 was that CMS decided that areas that have been affected by natural disasters could file, Jill, I'm not sure if they called it a waiver or an exemption.
I think they called it an exemption, a hardship exemption, like the
a hardship exemption if you were one of the physicians or any of the clinicians that were in some of the areas that were affected by natural disaster. Here in Florida, we got hit by hurricanes, also in Texas, the wildfires in California as well. So you might want to pay close attention when you go to that CMS website to see and to understand if you're in an affected area, the exact thing you need to do to submit for the hardship exemption. Jill, you may have something further on that.
Well, that's another reason to check your participation status early, is in that report that you see online for your participation status. It will tell you if you're in an area that's going to be considered. It'll also tell you if you're a small practice. It'll also tell you if you're in a HPSA shortage area and if that's going to affect any of your scoring methodology. It'll also tell you whether you're reporting as a group because somebody claimed you in their tax identification number, or if you're eligible to report as an individual, or if you're eligible for both and you can pick what you want to do. So checking your participation status early in the year and also later in the year, i.e. because if you're in an advanced APM that is trying to qualify, they have 4 times during the year that they can put in lists of physicians that are covered by the APM. So particularly if you're in an accountable care organization and you're new into that demonstration project, they may not report you right away in the first part of the year. And so that's why it's good to check early in the year, and it's good to check a little later in the year to see what your QPP participation status is. And it's really easy to do. You just type in your MPI number, poof, there it comes up on the screen, and it gives you this whole report that you can print, or you can just look at it online, or you can save it down to your computer so you have it for documentation purposes. So we didn't get to really talk about virtual groups. We will maybe do a little article on that since for 2018 we passed the deadline to sign up, but folks need to be considering putting together possibly a virtual group for 2019. So we'll get that in our next, some of our future articles, and the slides will be in the deck when it goes up on the macro webpage. But we'd rather make sure that we're getting to all your questions tonight, particularly related to 2017 in the next 60 days, or as you're gearing up for 2018, given that we have these longer reporting periods.
Well, I'd like to thank both you, Jill, and Michelle for tonight's presentation. I think it was really valuable for our members. And to our members, I'd like to just remind you, if further questions do arise, please turn to our practice management department at AACE, either through the email or by calling, talking to Michelle and her staff. They'll be able to if not get you the answer right away, at least point you in the right direction. And certainly when you speak to your colleagues and they have questions about MACRA, just remind them that this AACE is here to help support our members to not only participate in MACRA and the Quality Payment Program, but also to be able to get the most out of the program with proper reimbursement for all the hard work that you do in taking care of patients. The webinar should be available in the next 2 weeks, so please check back to the website. And I think that would conclude tonight's program. Once again, thank you to Michelle and Jill and to you, Alyssa, for hosting the program tonight.
Good night, everyone. And if you have any questions, please feel free to contact us via the MACRA mailbox. Thank you so much for attending.
Thank you.